delighted to have Professor Roger Barker with us today, who's been working on Parkinson's for 30 years. So I think he knows a thing or two about it, and he works in the Cambridge Brain Repair Lab. I think is the right place. Is it still called that?
It goes under different names. So I work at the Cambridge Stem Cell Institute, which is a brand new building, and the used to be called the Brain Repair Centre. It's now called the John Van Geest Brain Repair Centre. But people think when you say Brain Repair Centre, they think you're something out of Monty Python, to be quite honest.
Well, that sounds like the repair shop on the BBC, doesn't it, really?
Yeah.
Take it out and leave it. Really. Fix it for us. So what I'm going to do actually is kind of now hand over to Becky Jones, who works with Roger, and she will give a little bit of an introduction to the lab, and then we'll have Roger himself with his presentation, if that's okay with you too. That fine? Yeah,
that's great.
Excellent.
Thank you. Hello, and nice to see everyone remotely. So my name is Becky, and I'm the public engagement manager at the Cambridge Stem Cell Institute. So as Roger said, his group is split between kind of our institute and the brain repair unit as well. We in this Cambridge Stem Cell Institute are really passionate about finding ways for our researchers to connect to different communities and to the public and talk to them about what they do, and involve them more in what they do. And Roger has got a long experience in doing this for the Parkinson's and Huntington's communities. And I'm really pleased that we've managed to make this connection and facilitate the connection today. So Ruth got in touch with me a little while ago looking for someone to come and speak at one of these sessions. And we've then got in touch with Roger and connected the dots. And we're hoping to do lots more work with the Parkinson's community beyond these kind of update sessions in the near future as well. So that's why we're here today. That's why I do what I do. We also, there's someone in the call from Roger's group called Shalene. She's a postdoc in Roger's group and she works on stem cells. And Roger's going to be talking a bit about stem cells and Parkinson's, obviously, in his talk. We did create a little virtual tour for everybody to see our new building in the Geoffrey Cheer Biomedical Centre, where our Stem Cell Institute is based. Shalene did a little virtual tour for you, which I'm going to post in the meeting chat for anyone that wants to look at it. And I believe it's going to go on the website afterwards. So you can get a sense of where Roger works and the kinds of lab spaces we have in the building. Because obviously at the moment, no one can visit us due to COVID. So yeah, I'll post that and then I'll hand over to Roger to continue his talk.
Thank you very much, Roger. It's all yours.
Okay, so here we go. Let's see if we can actually get things to work. So I think probably the easiest way to do this is that I'm going to give my talk. If you have questions, if you put them in the chat, and then at the end I can deal with them as we're going along or at the end.
Yeah.
So I'm going to try and put this talk up. The trouble, actually I can't do chat when I'm on this. Can you see that slide?
Not yet. No, I can't see it. You can see it. Anybody see it?
No.
No one see it.
There's nothing there yet, Roger.
Okay, let's try. Hang on. Oh, I think I know I went wrong. So go share screen. Go there. Share.
Yeah.
You can see that.
Well done. Well done. Yeah.
And can you see one slide or all my slides?
We can see one in the middle and down and some down the side.
Yeah. How about that? Just the one.
Wonderful. Perfect.
All right. And I was told I could talk for 4 hours.
Just a little bit less.
Well, I'll see you after 1 then, Roger.
Yeah. We'll see you tomorrow.
Okay. Right. So I thought what I would talk about is I would talk a bit about something that I've spent many years working on, which is cell therapies, and obviously is very much embedded in the Stem Cell Institute in Cambridge. But I thought in order to do that, I would just explain a little bit about why we think about this. Where it's got to, and then how this therapy is developing, and where in the UK and in Cambridge we can contribute to this. So I guess the first question we have to ask ourselves when we're thinking about trying to repair the brain, especially around cell-based therapies, which is what I'll mainly be talking about, is what are we trying to repair in Parkinson's disease? So as you will be aware, Parkinson's disease affects multiple cell types, but in the brain, and it now is widely thought that it affects cells outside of the brain. And in fact, there's a whole theory that the disease doesn't begin in the brain, it begins in the gut, and it begins in the gut 10 or 15 years before you develop any neurological problems. So obviously, if we believe that that is the case, that this is a disease which has problems in the body as well as in multiple sites in the brain, how on earth can we repair all of that? You can change a tire on a car if it has a flat tire, but if it's got 3 flat tires, a carburetor, a battery, a steering wheel, and a gear stick that doesn't work, it's going to be harder to try and fix that with one approach. So it's important, I think, this, because a lot of people talk about these therapies as though they're curative. We're actually getting rid of the disease altogether. What we're really trying to do is we're trying to repair a fundamental pathway which does go wrong in Parkinson's disease. Now, I don't know if you can see my pointer here, but at the bottom of your brain, you have a stem, and sitting on that are your 2 cerebral hemispheres, and projecting out of that stem are some cells and their fibers which produce the chemical dopamine, which is what the main therapies in Parkinson's disease target. And on each side of your brain, in a thing called the substantia nigra, you have 500,000 dopamine cells. That's all you have. And when you lose half of those, 250,000, you develop the first motor features of Parkinson's disease. So what we would hope to be able to do is if we could put 250 or 300,000 dopamine, healthy dopamine cells into a brain, or keep 250 and 300,000 dopamine cells alive, we should, in theory, be able to get rid of all of the problems which relate to the loss of dopamine in Parkinson's. So that's not getting rid of all of the problems, but that is getting rid of the major problems. And as all of you will be aware, or most of you will be aware, when you are diagnosed with Parkinson's and you're put on dopamine drugs, the response is very dramatic. You actually almost go back to normal. But this is not a cure. So a cure is when you actually get rid of the disease altogether. So when you turn up with a pneumonia, so an infection in the lung, someone gives you an antibiotic, at the end of that course, the bug will be dead, the lung will be clear, and you will be cured. You will not have pneumonia. What we're trying to do here is we're trying to repair a system, either replace what's missing or grow back that which is deficient, but the disease process will carry on. So this is not a curative therapy. So if we just take that as our starting point, so the key thing I want to do here is I want to try and rescue these dopamine cells, which project out of the bottom of the brain up to this structure deep in the brain called the striatum. So how am I going to do that? Well, just think of your garden. So if I wanted to, my dahlias weren't doing particularly well, how could I make my dahlias look better? Well, the first thing you could do is you could chuck on some fertilizer. So you say, well, those dahlias aren't looking so well. Perhaps if I feed them with things which dahlias like, I know nothing about this, I should say, you put on fertilizer for dopamine cells, can I grow that system back? So that's been an area that people have been very active in. Can we actually put growth factors, factors which stimulate the growth of dopamine nerves and dopamine cells to repair that which is broken? So the idea is trying to improve what's already there. The alternative is to replace a very specific type of dopamine cells, that doesn't really matter what they're called, A9 dopamine cells, and replace them. So the idea here would be, I'm just going to put back that's which missing. So my dahlias aren't looking very good. Let's just give up on them and replace them with a whole new bunch of dahlias. So that's the strategy which I'm going to be talking about tonight. Can we replace the lost dopamine cells which have died as a consequence of the Parkinson's disease? So that's the first, that's what we're going to try and do. So you're all in the lab, you're all decided, you've all signed up, said, okay, Roger, I'm with you on this one. We're going to repair the Parkinsonian brain. And what I mean by that is we're going to try and find 200 to 300,000 dopamine cells, put them in the brain to replace those that are missing. So who are we going to give that to? Well, we're going to give it to people with Parkinson's. Well, is everyone with Parkinson's the same? And that is an important question. And actually, we started a study, which makes you feel ancient now, in 2000 and 2002, where we collected every single person who could conceivably have Parkinson's in Cambridgeshire. So this was a study which is currently still going, and we repeated it 10 years later. So this told us, for example, that the average age at which you get Parkinson's is about 69. That if you look at, if you're sort of morbidly inclined, if you look at the death rate in people with Parkinson's disease, it is no different to the death rate in the community. So on the community level, Parkinson's does not shorten your life. you have exactly the same life expectancy with it as you would if you did not have this condition. And if you look at death certificates, which some people enjoy doing, then actually, if you have POC disease on the death certificate, only about 1 in 10 people with POC disease have POC disease on their death certificate at all, i.e. it's something you die with rather than of. But for our discussion tonight, what we wanted to do is we wanted to collect everyone with POC disease, follow them over time, and see whether they all behave the same way, which we suspected would not be the case, but we didn't know how they would differ. So we collected all these patients, we followed them over time. We just published the last paper on following these people up. And what we did is we said, actually, there seem to be 2 types of POC disease. There probably aren't 2 types, but there are probably 2 extremes. There are clearly a group of people who tend to be younger. They have some very subtle thinking deficits. And there is another group of people who are older patients when they present who have problems, very subtle problems with thinking, which you can pick up when they come in to clinic. And these problems tend to be the ability to produce list of animals. So people couldn't produce more than 20 animals in 90 seconds. And then there's a test where you have pentagons, which you may have been shown in clinic, which overlap, and people have problems with that. And if you did this at presentation, so if you were less than 72, had none of these deficits, over 72 and couldn't do either of these, then your prognosis was very different. The patients who were older, who couldn't do these relatively simple memory cognitive tasks, ended up developing a dementia very early on in their disease course. So these people did rather badly. And if you develop a dementia in POC disease, then it means the disease is not restricted to the dopamine cells. It has spread throughout the brain and is causing all sorts of problems to do with thinking. Now, that is obviously disappointing for people who fall into that category, but it does have major therapeutic implications. The question is, well, why do some people do badly and some do better? We found some various explanations that genetic background, age, and inflammation. But for our discussion tonight, it has important implications for therapy. In a simple way, if I say, well, actually, we don't worry about this. You're all in my lab. You're all making dopamine cells. We're just going to grab the first 10 patients that come through the door and give it to them. We'll put the cells in the brain. We'll wait 3 years, and then we'll say, how are you feeling? So let's say we have 5 of the younger patients, 5 of the older patients with some of these problems. The 5 younger patients say, I like that cell. You and your team, Roger, have done a crackerjack job. I feel terrific after 3 years. The older patients who have a different type of POC disease, more aggressive, will say, actually, do you know what? 3 years down the line, I've developed all sorts of problems with hallucinations. I can't think properly. My walking's not so good. Your therapy hasn't helped. In fact, I think your therapy's made me worse. So you've got 5 people who've done well, 5 people who've done badly. You sum them together, you say, no different. Let's bin it and give up on it. And that has been a problem with this whole field, that people have actually not selected the people who may be appropriate for this type of therapy. So whilst the group on the side with the older patients with these cognitive problems are not suitable for the cell therapies, they are the perfect patients for all of the new therapies which are now emerging, of which there are a large number of trials with drugs designed to try and slow down the disease, because these people have a more aggressive form of the disease and should do better with some of these disease modifying therapies. Whereas the group on the other side, the younger patients who don't have any of these thinking problems, are probably the ones who do extremely well with dopamine replacement therapies, particularly dopamine cell-based therapies. So this is how we're starting to think about POC disease, which isn't particularly new in medicine. If you think about people with cancer, when I was a trainee a long time ago now, 30, 40 years ago, if you had breast cancer, you had breast cancer. Everyone got the same treatment. That was one disease. Now it's recognized there are many different types of breast cancer, and you give different treatments for different types of breast cancer. And that, I think, is how we're going to have to start thinking about Parkinson's disease. But for our discussion today, we said we want to pick the patients we think are going to do best, who have a disease which is mainly around the dopamine system, because that's what I'm going to repair, and we think it's that particular type of disease. Okay, so we decided on that. So then the question is, well, what's happened? Has anyone ever tried this before? And has it been successful, disastrous, or unclear? Well, you can already tell from what I've said that we know something about this, because people have already tried this to some extent. So the first thing you need to decide is, okay, so I'm going to put dopamine cells back into the brain. So where am I going to get my dopamine cells from? Well, obviously, I can't get them out of someone else's brain, because A, they won't survive if I took them out, and also if I took them out of someone else's brain, they would have Parkinson's disease and I would be then repairing somebody else. So then they like filling a hole, you'd never finish. So you have to consider, where can I find dopamine cells to put into into the brain to replace those that are missing. So people have looked around and they said, well, where else in your body do you produce dopamine? So you have some that sit by your carotid artery, which is the artery in your neck, called the carotid body. They've yanked those out and shoved them in the head. Didn't really work. The adrenal gland, which sits next to your kidney, which produces adrenaline and gets you very excited when you're listening to a talk like this, does produce a little bit of dopamine. So they've shoved it out of people, cut it out of people's tummies and shoved it in its head, but it produces almost no dopamine. So it doesn't really work. So those ideas of finding dopamine somewhere else in your body and shoving it in your head has been explored, doesn't really work. So that's not really an option. So then the question is, well, where else can I get dopamine cells from? So one place you can get it from is if women go for termination of pregnancies, so abortions, can we take the developing dopamine cells out of the aborted fetus, take out the cells which are normally going to develop into the dopamine system from that fetus, and put them into the brain of someone with Parkinson's? And that's what I'm going to largely talk about, because that's what's been going on now for nigh on 25 years. Nigh on 35 years, sorry. An alternative is to say, well, can we make a dopamine cell from a source that's a little less ethically contentious and which I could actually produce in large numbers? So one way to do this would be to get human embryonic stem cells. So embryonic stem cells are what we all were. So at some point, I would have been talking to every one of you would have been a stem cell, because an embryonic stem cell is what you derive from. So when the egg's fertilized, that divides and it becomes the embryonic stem cell. So that can give rise to any cell in your body. Obviously, what we want to do is turn it into dopamine cells, and we can do that now with quite a degree of success. Now, obviously, where do I get embryonic stem cells from? Well, people who go through the IVF program, so they have fertilized eggs, they're put in the freezer. Some of those eggs are not, fertilized eggs are not used. You can use those to grow up into a small number of stem cells, a thing called blastocyst, and then you can grow a cell line out of that. So you can use embryonic stem cells. And then the third area, which people have got very excited about since this was discovered in 2006 and 7 in Japan, was that you can take adult cells. So the idea is you take a bit of skin, a bit of blood, you trick it into becoming a stem cell, and then you turn that stem cell into a dopamine cell. So this has the potential that the patient could provide the material by which they could repair their own brain. There are problems with that. Obviously, you've got Parkinson's in the first place. I'm taking cells from you to make dopamine cells. Might not be the smartest move in the first place. But nevertheless, these so-called induced pluripotent stem cells. So there are three main sources you can use: those from spare embryos, embryonic stem cells; those from the aborted fetus, primary fetal cells; or those which are made from adult cells, which are reprogrammed back to things that, like embryonic stem cells, which are called induced pluripotent stem cells. They're all rather technical, but basically stem cells versus fetal tissue. So where have we got to with all of this? What's been the history to date? Well, if you look at fetal dopamine cells, so this has mainly been done by a team in Sweden. So here in the 1980s and 90s, they took people with regular Parkinson's disease and they transplanted in dopamine cells which had been dissected out of aborted fetuses. And when they work well, they work very well. So this is a patient who was filmed by my colleague Tom Faltony in London. This is someone who has had Parkinson's disease for about 35 years. He has had a transplant of fetal dopamine cells 25 years ago, and he is currently on no medication for his Parkinson's disease. So this person has been treated by putting replacement dopamine cells in the form of cells derived from aborted fetuses. So this demonstrates that if you do it in, this hasn't happened in everybody, just a few cases, when it works spectacularly well. So I think most people would say, if I look like that 35 years in my Parkinson's on no treatment, bring it on. But not everyone did that. So, but there is evidence that you can get long-term clinical benefits, and that's now been published. There's also evidence that these cells do actually survive. So it's not just that the patient thinks they're getting better, so they get better. There's evidence that they can survive. So this was a patient who was grafted in Sweden in the late 1980s, who died in his late mid-80s, the early part of about 2011, I think. when they took his brain out and looked at it. This is the side over here which didn't have a transplant. He only had a transplant on one side of his brain, got dramatic improvement. There is no dopamine there at all. This brown smudge is dopamine. On the side that had the transplant, it looks perfectly healthy. So a quarter of a century after these cells were put in, despite the fact that the brain has Parkinson's, the transplant survived, the patient got better. So they work long-term clinically, they survive long-term. Other factors like quality of life, I mean, we're very good at measuring things, but actually if you think you actually can improve people's quality of life, that makes a huge difference, and that's been shown. And also importantly, this was a study done on this patient over here. So the patient who died in 2011-12, in 1998, he came over to London and had a scan where his transplant was stimulated to release dopamine to see whether it really worked in the way that was thought. And it was shown that it released dopamine, the transplant released dopamine, just like a normal dopamine cell. So this patient improved, came off treatment, had a transplant that restored dopamine to normal in the brain, released dopamine in the normal fashion, and that survived for a quarter of a century. So needless to say, things didn't go quite according to plan. So in 1992, when Bill Clinton came into the White House, he sanctioned federal funding for fetal transplants in America, which to that point had not been allowed in the public sector. And they did two trials where they took patients. So they did two big trials, which were published 2001, 2003. And in these studies, they said, we'll get a number of patients. So in each case, about 30 or 40 people. Half of them had cells put in the brain. The other half had just pretend surgery. So if we were doing it tonight, you were all involved with this trial. All of you would go to theatre. All of you would sit in the hospital for several days. Half of you would have cells put in the brain. The other half of you would just have a little hole drilled partly through your skull so you can feel there's a dent in it, but nothing would be put in your brain. And what they showed at the end of this was it didn't really seem to show the benefits, which I've shown you in these other cases. And the question is, well, why? Why did these studies not show benefit, whereas I've shown you a case that did extremely well and other patients who've done very well? Well, if you actually look at these studies, you can see that they're absolutely identical, all of these studies. So all of these trials are exactly the same, apart from the fact they use different types of Parkinson's patients. They use different doses of cells. They delivered them in a different way. They suppress the patient's immune system in different ways for different periods of time. They looked at different outcomes for the trial, and they followed them up for different periods of time. In other words, these trials were all vastly different. And just to take you back to the 1950s, some of these trials were essentially like taking a whole group of people with chest infection in 1952, giving them 100 milligrams 3 times a day of penicillin, and saying, I'm going to look at a chest x-ray 5 days later and see if they're better. What you'd have found is some of the patients did get a bit better, but not many. And the reason they didn't was they all had a different type of pneumonia. You'd probably given the wrong dose of antibiotic, and you hadn't waited long enough. The conclusion would be penicillin doesn't treat chest infections. Antibiotics don't help bugs. Let's abandon antibiotics and just carry on sending people up to sanatoriums in the Swiss Alps. So you have to interpret this data very cautiously because it's very difficult to compare. The consequence of this is that we identified what we thought were key factors, which would mean that we could plan a new trial which would better address and show whether this therapy worked. And that's what we did. And it's a study that was funded by the European Union when we were part of the European Union back in 2010, where we took people who we thought had the type of Parkinson's we think is the best type. We prepared the tissue in a particular way, transplanted it, and the final patient in that trial will come to the 3-year endpoint next March and April, and we'll be able to report as to whether it works. Now, part of the problem with that trial was that for the 11 patients that we transplanted, we had a further 84 surgeries planned for them that we could never use because we never had enough tissue. So regardless of the outcome from this trial and the proof that this type of therapy could work, it could never be a proper therapy for people because we simply don't have enough tissue in a reliable fashion in order to do it. So then you say, well, let's make stem cells because they have the advantage that we can make lots of them, we can control them, and we can define what we're going to put in. So as I've said, these are the two main types that we've been thinking about: embryonic stem cells and these induced pluripotent stem cells. So where have we got to with these therapies? So when we started on this work, which was in the early part of this decade, we set up a group which brought together all the teams around the world who work on this therapy to try and solve it together. We called it the Parkinson's Stem Cell Research Group. The Americans didn't like that. So they called it G-Force PD because that sounds much more dynamic, like the A team. So that is the G-Force PD team, which met last year in Cambridge and was due to meet in April in New York this year. But our friend COVID-19 got in the way of us meeting. So we didn't have a meeting this year. So this is a group of people who work together to try and solve how we can take stem cells to patients with Parkinson's disease. And who are the people who are working on this? So when we started our TransEuro study, which was the fetal study in 2010, and grafted our first patient in 2015, world investment in this treatment was almost non-existent. There was probably $0 that went into this work in 2015. And by the time we grafted our last patient in 2018, in excess of $1 billion is now being invested in making this therapy work for people with Parkinson's disease. So what has happened is that things have started to expand in terms of who's interested. So we are in the process of setting up a trial called STEM PD, which involves the Stem Cell Institute, the hospital in Addenbrooke's, the GMP facilities which make these cells, which is where you'd make cells if you're having a bone marrow transplant, and that's called STEM PD. We are due to start that trial at the end of next year, assuming all the regulatory people approve it, and that will be done in Cambridge and in Lund in Sweden. And linked to us is a company called Novo Nordisk, who are the fourth biggest pharma company on the planet, and they now have a major program developing cell-based therapies for Parkinson's disease. So if this really works, and we work very closely with them, this could become a mainline therapy very quickly because they have the money and the wherewithal to actually take this through the clinical trials, get it registered, and it would be available for many people if it was shown to work. Our colleagues in New York, a chap called Lorenz Studer, he set up his own company called Blue Rock. They've now been bought by another company called Bayer, who are another one of the major pharma companies in the world, who are pushing forward with a cell-based therapy for Parkinson's disease. In Chicago, they're setting up a trial by a company called Cellular Dynamics, which is funded by Fujifilm. So they are moving towards a clinical trial in Chicago. There's a company in California called Aspen Neuroscience, which are using patients themselves as a source of cells for transplantation. So they want to treat patients using their own cells. Japan have a company and major funding since they invented iPS cells. They have massive amounts of money that's been going into their research to take this to clinical trials. In China, there are all sorts of funny trials going on, but there are definitely trials going on with different stem cells. And then there's a very dubious trial going on in Australia, which is well advanced, which I will tell you at the end, because it's a word of caution about how some of these therapies can develop. So as you can see, this has become a major industry, and people really see this as a therapy which has got legs. Novo Nordisk would not be investing in this if they didn't think that there was a real commercial potential to make this really work for a large number of people with Parkinson's disease. So where has it got to? Well, our colleagues in Japan, Jun Takahashi, had this paper in one of the big science journals, Nature, a couple of years ago, where he demonstrated if you took, so in this case, I think he took blood cells from patients and blood cells from people without Parkinson's disease, he reprogrammed them into dopamine cells, transplanted them into monkeys, followed them for 2 years. The monkeys got better. The monkeys had been given Parkinson's with a toxin. The monkeys got better, and they got better regardless of whether the cells came from patients or not patients. So this demonstrated that they could take blood cells, turn them into iPS cells, these induced stem cells, turn them into dopamine cells, graft them into monkeys. They work very well, and people get better, the animals get better, and that has led them to start a clinical trial. So in 2018, they grafted their first patient with Parkinson's using this stem cell source for dopamine cells. They did one half of the brain in 2018 in November. They did the other half in June of 2019. And I think they may have done 2 or 3 other patients since then. So stem cell dopamine therapies for Parkinson's are now happening in Japan. The other approach is this autologous approach, where you take the patient's cells and convert them into dopamine cells. And there was a paper that appeared in the top medical journal this summer in the New England Journal of Medicine, where the patient is a single patient. They took skin cells from this patient, they turned them into dopamine cells, and then they grafted them back into his brain. This was a very dubious study, which I'm happy to discuss afterwards. But essentially, they demonstrated they had a protocol that didn't really work. They then transplanted them into the patient, where they showed there was no change in dopamine levels in their brain. They then demonstrated that the patient didn't actually get better, which is what you'd predict, because the cells they made weren't very good, and they didn't show any change in the dopamine signal. But this bottom graph, which is how the patient saw themselves, quality of life, went back entirely to normal after having the transplant. So this probably is all because the patient themselves had paid several $1 billion for this therapy. So they were absolutely certain it was going to help them. But there was no evidence it worked. And that's because they hadn't got a protocol that worked properly. Now, these embryonic stem cell lines that I'm talking about, protocols were developed, as I say, nearly 10 years ago, where you can make very nice dopamine cells from these sources. They work just as well as fetal cells. And we are now, as I say, moving towards a clinical trial next year with these cells, in conjunction with our colleagues in London, Sweden, who've been the ones who've primarily driven the science behind this. Now, just to give you some idea of why this is very exciting and why companies are getting involved with this, the ability to scale this up is actually extremely easy. So if I start with a 6-well plate, which is a bit bigger than my mobile phone, and I start today, which is whatever it is, October the 15th, then if I went into the lab and knew what I was doing, which I don't, but let's assume I do, then by the end of this month, with that 6-well plate, I would have made enough dopamine cells to treat 300 people. So I would have made enough dopamine cells just from that. I can expand them and then turn them into little vials. So one plate, I can treat 300 people, 10 plates, 3,000, and so on. So you can see that with one production run over less than a 3-week period, I could produce enough dopamine cells to treat the entire Parkinson's population of Europe. So the cost of making that isn't very high, and therefore I could probably charge a reasonable amount for it and get quite a good return on my investment for that. And we already have proof of principle that this approach using dopamine cells would work. So that's why people have suddenly woken up to this could be a really great way forward. Now, the problem is that other people have taken a different type of stem cell. So these are a stem cell which are a bit odd because they're not a fertilized egg. They take eggs and they pretend to fertilize them, and then they turn those stem cell-like cells into dopamine cells. And this has been run by a company out of California, which does its trial in Australia. And they have now moved up through 3 or 4 phases of patients. And this is a sort of word of caution, because what these people showed in their preclinical data, so in the data before they went to patients, was when they grafted these cells into their monkeys, the cells didn't survive. So that's not a great starting point. They then looked to see whether it actually helped the animals. So here they had their animals, they made them Parkinsonian by giving them a toxin. They grafted in their cells at low or high dose. And over a year, which is what the T12 is, the animals got better. So you think, well, that's pretty good. I don't quite know why, because the cells haven't survived. Actually, if you look at this blue bar here in the graph, nothing was done to the animals. So they didn't have any injections of any cells. So they actually got better on their own. So the problem with this is that the best, well, the worst, that if you like, whichever way you look at it, what's likely to happen in this trial, none of the patients will get better because nothing will survive. And it will be seen that stem cell therapies don't help POG disease, but it's the wrong type of stem cell and it's all been done incorrectly. The worst is some of these people will die as a result of this therapy. People will say stem cell therapies not only don't work, they kill people. We shouldn't do it. And all of what I've told you before then becomes obsolete and people won't take it forward. So this is a worry, and in China they've done exactly the same. That's the best picture they can show of their dopamine cells. So there are words of caution here that there are people going to clinical trials with cells which don't merit a clinical trial, but the reality is that these therapies are approaching and are coming into the clinic. So just to conclude, I would say that there is a rational basis for what we do. So going back to where I began, what I'm trying to do is I'm trying to produce 200,000 to 300,000 dopamine cells to replace those that are lost in Parkinson's. These will be young, new, healthy dopamine cells. So if we put them in the brain, they will survive, they will make connections, they will release dopamine, and they will repair that bit of the brain. And what we have so far is that that will work for at least 25 years, which for most people will see them out. There have been mixed results, and that in part relates to how people have done their trials in terms of choosing the right patients, how they've suppressed the immune system. And so it's very easy for things to go wrong in these type of trials. And as I've said, there are stem cells being used out there which shouldn't really be tried in patients because there's no evidence in the lab that they would work. But those that do work, we have great hope that these will definitely help people. And so what does this mean for the future? Let's assume our trial, which starts next year, is successful. Novo's trial is successful. It's all looking very good. This is a therapy which clearly replaces dopamine, makes patients dramatically better. What would this look like in the future? So if we could demonstrate this and this works, and I will retire in about 8 years' time, and this is what I want to happen by the time I retire. If this really does work, then what would it mean for people with Parkinson's? Well, this is a standard way in which you treat someone with Parkinson's. You stick them on a bit of perhaps rasagiline, sledgiline to begin with, may put them on a reticulatine patch or a bit of ropinirole, give them a bit of Sinemet or Madapar. They then develop some involuntary movements, we give them a bit of amantadine, gets a bit harder, we give them some apomorphine infusions or deep brain stimulation, then we give them Duodopa. That's the sort of standard therapy we give over the years. If this worked, and it worked as effectively as we think it could do, that's what the treatment would be. You're diagnosed with Parkinson's, we confirm you've got it as best we can, we check you respond to a dopamine agent, we give you a stem cell transplant, end of story. It wouldn't cure you of the disease, but it would prevent you having to take all of those medications and all of the complications that those medications bring with you. And whilst we're doing all that, the clever scientists in the lab will say, actually, why are we bothering to transplant cells in? Can't we be a bit smarter than this? So can't we actually take some of the cells you already have in the area which has lost dopamine, which is this thing called the striatum? There are support cells in the brain called glia. Why don't we just turn 200,000, 200,000 or 300,000 of them into dopamine cells? Why don't we directly reprogram the brain back to dopamine cells? And so people are now working on this strategy that you don't transplant in cells, you inject factors into the brain where dopamine normally works and is missing in Parkinson's disease, and you convert a few 100,000 of cells you don't really need into dopamine producing cells, and that stops you having to have a transplant, gets around all the problems about immune rejection, and you've actually repaired the brain using your own cells, which obviously has great value. That's still in its infancy, but you can see there is great hope that these type of therapies could dramatically change the future of Parkinson's and how we treat it. So finally, I speak on behalf of large numbers of people. That was our group when we were allowed to meet in a non-socially distanced time earlier this year. All the various people who've helped with the work over the years, only some of which I've discussed. So I will stop sharing at that point. I see various people sent in questions during this time, which I couldn't really see when I was looking at my slides. So I don't know, Ruth, whether you want me to go through these questions or...
If you, I mean, there's 11 of them I've got. So if you could briefly go through the ones that make different points, because I think some of them will, ask the same question, if that's okay.
Yep. So I'm going to start off. So the first question was, what makes a cell survive and why so few? That's a very good question. We don't know why so few cells survive. In terms of repairing the brain Parkinson's, because we actually need relatively few, only a few 100,000. The survival rate from our stem cells is about 10% at the moment. So if we put in 2 million dopamine cells, you'd have 2 million dopamine precursors or stem cell derived dopamine cells. If 10% of them survive, you'll be fine. So we don't know why so few survive, but it's not actually critical because the number you need to survive is relatively small. So we can do it with the cells that we've got at the moment. Is there a way these can all work together? Will you be able to make enough for everyone? Well, I think I've answered that question saying that the manufacturing of these cells is very efficient and it doesn't take very long to make a large number of these cells. And the beauty of them is once you've made them, we put them in the freezer. So at the moment, we have 300 vials sitting in a freezer at the Royal Free Hospital in London, which have been used for various preclinical testing. Those will be the cells that will go into people's brains next year, assuming all the preclinical data looks as good as we think, and actually the cells look fantastic. So when the group in Sweden have transplanted them into their models of Parkinson's disease, they look absolutely crackerjack. So there's no reason they shouldn't work. What is the PD population of Europe and the UK? Well, I know in the UK it's about 130, 140,000 people have Parkinson's disease.
Yeah.
As I said, not everybody's going to be suitable for the cell-based therapy, but if you assume only a quarter of that is, that's still 30 to 40,000 patients. I don't know what it would be across Europe. It's probably 1 million across Europe with people with Parkinson's disease. So it is actually large numbers of patients, so several 100,000, which is obviously a big enough market for the companies to think it's worth investing in. Does it always work? Are toxin-induced Parkinson's the same as Parkinson's disease? Yeah, this is a big question, really, to be honest. They don't always work in patients, and that's for some of the reasons I've explained, that the patients are not all the same. People have used all sorts of different approaches. One of the big questions we always ask is, are the things we do in the lab useful for patients? So when we get Mr. Mousy or Mr. Ratty and we give him a knockout dopamine cells and then study him, is that Parkinson's disease? Well, it clearly isn't Parkinson's disease. It looks nothing like it. There's nothing really wrong when you look at them. But what it is it's a model which has a loss of dopamine. So given we're trying to repair and replace dopamine, it's a reasonable model. So we use the models not to model Parkinson's disease, but to model dopamine loss. And can we replace dopamine, which is what we're trying to do with this therapy. Is the transplant a complex operation? Well, it depends who you ask. So actually, it's not that difficult, he says, not being a neurosurgeon. It's a long operation, but actually in the world of neurosurgery, it's quite a big target they're trying to hit. They spend every day yanking bits of brain out to biopsy things which don't look right. So this is very standard for them. So, you know, although it's a complex, although it's a long procedure, it's actually relatively straightforward. I say that obviously not having had an operation myself with the neurosurgeons, but essentially nowadays we can accurately locate where we need to put things through scanners. They have all the apparatus for doing it. So actually it's not as complicated as you think. And the idea would be moving forward, if this really worked, you would come in on a, what day is today? Thursday. You would have your transplant on Friday and you'd go home on Saturday. There'll be no need for you to stay in long term for this. Because amazingly, apart from a bit of a headache from when they've gone through the skin, the brain itself has no pain fibers, so you wouldn't feel anything there. And you could just go home pretty much straight afterwards. The criteria for taking part, yes, that's what we're after. We're after the patients we think in these first trials who are the ones who are going to do best. So these will be the younger patients, less advanced disease, who have had a good response to medication and don't have any other major medical problems. That's not to say that it won't be more patients will be included going forward, but you always at the beginning choose the patients you think are optimal. I'm aware of other work that says there are 4 types of Parkinson's, or even 7. Yes. How does that fit with your 2 types? Yeah. Well, I don't want people to think that I think there are only 2 types. I think basically people with Parkinson's sit on a spectrum, and there are people who have young onset, no real thinking problems, respond spectacularly to dopamine, and that's really where all the problem are. And then there are sadly people who develop Parkinson's quite late in life, typically have a whole host of problems from the word go. Clearly the disease is just not dopamine, it's the whole brain has been affected. And you know, how you split up between that is a little bit depending on who you study and such like. What we've done is we've tried to collect people as they exist in the community rather than people who come to clinic. Because obviously if I looked at my Friday clinic of Parkinson's and said, what's the average age to get Parkinson's? It would probably be about 48. You know, how many people would be willing to have a cell or gene based therapy? About 100%. So most of the people who come to my clinic are a highly selective group, which isn't representative of the population. So I think it's difficult, but I think we know who are going to be the ones who are going to be optimal for this type of treatment. Oh, Lucy. Has the problem of early transplants producing dyskinesia been solved? So Lucy Annett, this is a question from. So Lucy has done much of this wonderful work with Steve Dunnett on the fetal tissue many years ago. So one of the complications which I didn't mention is that some of the patients who had these transplants of dopamine cells went on to develop involuntary movements, which you see in everybody who takes L-DOPA over a number of years, so-called L-DOPA-induced dyskinesias. Now what you saw were people who had transplants who developed these involuntary movements, so-called graft-induced dyskinesias, which of course I can always get rid of L-DOPA-induced dyskinesias because I can get rid of L-DOPA. I just say don't take the medication. You might not like that, but I can get rid of them. the trouble is I can't get rid of the transplant when it's there. So there was huge discussion as to what caused these problems, which is seen as a major issue. And it's probably related to the fact that when you put the cells from the fetal brain into the Parkinsonian brain, some of the cells you get are not the cells you want. So you don't just have dopamine cells, you have all sorts of other cells. And it was thought that some of those drove these involuntary movements, so that the stem cell derived dopamine cells should not have this particular problem. But I have to say, that's what the regulatory agencies worry about. And today we were meeting with the Swedish equivalent of the MHRA, which licensed drugs, and that was their major concern. Why wait? Yeah, well, I agree, but we need to do things properly. Becky's put something about me banging on about something else. Could someone with Parkinson's respond to a dementia study medicine if they've been diagnosed with both? Could someone with Parkinson's respond to a dementia? So one of the things which I haven't really talked about here, but it relates to this question, is I've talked about using these cells to replace the dopamine cells as though it's a monotherapy. That's the only treatment you would need. Now, obviously, as I've already said, there are lots of other treatments that people are trying to slow down the disease. So some of you will know there are vaccines against the protein linked to Parkinson's, it's alpha-synuclein. There are drugs which are used for one indication. So there's a lot of interest at the moment, for example, in things like Ventolin, whether that changes how much protein you produce in your brain, which may drive Parkinson's. There is no reason to believe that in the future you couldn't have a stem cell transplant, assuming it works in the way that we think, as well as drugs which are designed to slow down the disease process. So these are not mutually exclusive. If we find something that is disease modifying, slows down the disease, and you have a stem cell transplant, there's no reason you couldn't use the two together. So I think I've gone through most of the questions, but I'm happy to take any others or any other points of clarification or correction.
I've got one here, which I'm asking at the bottom. Hang on. What do I do now?
If you just press return.
Okay, woo, what have we done? Okay, you got that?
No.
No? So just ask it.
Yeah, just ask it the
How
old-fashioned way.
Yeah, with words. How does this affect people who possibly have a genetic mutation and not idiopathic Parkinson's?
Good question. So first thing to say is that people who have genetic forms of Parkinson's are actually quite rare. So although there are large numbers of genes associated with it, when we looked at the first 550 patients that came to our research clinic, only 2 of them had a genetic form of Parkinson's. So the vast majority of people don't.
Okay.
Depending on your genetic abnormality determines whether you'd be good for it or not. So the rare ones are people who have Parkin, which tends to present very early in life. They're very dopamine sensitive. They may do very well with these transplants. People who have probably the commonest known genetic mutation is a thing called LRRK2. I don't think that would stop you doing a transplant, because there are people who carry a variant in a gene called GBA. So the GBA variation, which is a gene which probably makes the disease a bit more aggressive. It may be they're not ideal in the first place. But given that the vast majority of people don't have genetic forms of it, I think it's going to be not a major issue determining whether we use that or not.
Thank you.
Could it replace DBS? Yes, it could. So if this worked, the advantage of this therapy is it's a one-off treatment. So if it really works, you have the cells put in. It probably takes a couple of years for them to work. So that's why you'd have to go quite early. But you wouldn't have top-ups. You wouldn't need more cells. You wouldn't need wires running under the skin. You don't need batteries. You don't need any of that. So in theory, if this really worked, you could have this as a one-off treatment and you wouldn't need DBS or any of these other therapies. Can you give some of this?
That would affect the age of patients, wouldn't it?
Say that again?
If DBS is replaced, that would affect the age of patients, wouldn't it? Because older people can have DBS, can't they?
Yeah, and there's no reason older people couldn't have cell-based therapies. So whenever you're trying to do anything for the first time, what you want to do is you want to make sure everything's in your favor. So obviously you cherry pick the people you think are the very best. But then once you've shown it's safe, which of course is what we've got to demonstrate, and then you show hopefully that it's working, you can start to push the envelope. You can start to say, well, actually, let's see more and more people we can include in that. The problem with DBS actually was the opposite. So the problem when deep brain stimulation first came along was they gave it pretty much to everybody. So there was a great concern in the 90s that this therapy wasn't as effective as you thought it was going to be, because actually lots of people didn't do very well. And that's because they chose all sorts of patients who weren't particularly responsive to their medication, had all sorts of other problems related to age and such like. So there's no reason that someone who's say 85, who's doing extremely well with dopamine, has a really only Parkinson's which responds to dopamine, couldn't have a cell-based therapy. So at the moment, whilst we've restricted the age, that's merely so we can get evidence that it's safe and we can get it to actually do what we think it's going to do in the optimal group. But ultimately, it would benefit anybody who has, regardless of age, a disease which seems to be localized to the dopamine system and doesn't have many complications outside of that.
Yeah, I've got one final question. In the early days, the cells used to take on the properties of Parkinson's, didn't they?
Yeah. So
that doesn't happen now.
Well, it does. So that transplant I showed you 24 years after it was put in, about 20% of those cells had the pathology of Parkinson's disease, but 80% of it didn't. So you don't normally see the pathology in the transplanted cells till they've been in for 10 years. And then at sort of 20 to 25 years, about 20%. So the transplant will probably be completely consumed by the Parkinsonian process after about 60 to 70 years. I don't think most people will be around 60 or 70 years after they've had a transplant. There's something else, because you'll be about 130. So, but it is an interesting question. Yeah. So what people are now thinking about doing is, because the pathology spreads from the Parkinsonian brain to the transplant, could we make the transplant immune to that? And because this protein called alpha-synuclein is the one that's thought to spread into the transplant and cause the pathology, could we make a stem cell into a dopamine cell that has no alpha-synuclein in it? And that's what people are trying to do now. So could I have a stem cell that doesn't have alpha-synuclein but still forms a healthy dopamine cell, in which case that cell could never, ever get the pathology of Parkinson's disease because it's not got the protein that causes it. So people are trying to take it to the next stage, but at this stage, we've still got to prove that we can actually do it safely and effectively with the sort of standard cell, if you like.
But the DBS, once you've had DBS, you can't have any other treatment. Is that correct still?
That's at the moment, but that's because if I said, oh, I want to transplant cells into people with DBS, they'll say, well, what's the evidence that the cells behave with DBS in exactly the same way as if you don't have DBS? And I would say, I have no idea because I've never done the experiments.
Right.
So at the moment, we've said what would the trials will be in people who have not had DBS, but there's no reason, because the DBS electrode ends up in a different place to where the cells would be. There would be, in theory, no reason you couldn't have both therapies.
I'm going to say now that it's nearly 8 o'clock. Is there one last question from anyone? There is one here from someone who said some of your views on how people can live as well as they can with their symptoms. So do you have any comment on that? The last one?
So I think the key thing is, so the thing I always say, so I sometimes give a talk about, if I had Parkinson's, what would I do? I would be very physically and mentally active. I would hitch myself up to the Parkinson's UK group. I would find out what research is going on. I would decide whether I'm interested in any of those therapies. I would sign up for trials and let someone else have the first one, and then I'm happy to have the second one. But I think trying to keep yourself physically and mentally active and look out for what's happening is important. And it is a very optimistic time. So when I started research on Parkinson's 30 years ago, the fetal tissue transplants were coming on. By the turn of the century, they were dead because people knew they didn't seem to work based on those trials I've said. There was nothing else that was happening apart from DBS. Now there are tons of trials going on about all sorts of therapies. So it's whilst it's never good to have Parkinson's because you'd be better off not having it, the therapies out there at the moment and the trials are huge. So this is a very exciting time for trying to tackle and actually really make a difference with this disease. So I'm very optimistic.
Can I say thank you very, very much? That was absolutely fascinating and so clear.
Oh, thank you.
Which
Can
makes
I also come in, Roger, and say, as I said before, I have no connection with Parkinson's other than my association with the committee and this branch. but I found that most enthusiastically enlightening, the way you put it over. For somebody who has no knowledge, I could actually sit and watch. I don't understand the technical terms, obviously. I don't understand the drugs and the things you're talking about. But having said all that, the way you put it over, the way it came through, I could hopefully understand some of the things you're talking about.